informal settings in Khayelitsha in South Africa, and you can see the type of environment that our children have to grow up in. In terms of family structure, we found that 28% of the children were cared for by single mums, 20% were married couples with both parents involved in the care of the children, 9% of patients were cared for by other family members, either a grandmother or an aunt, and 43% of the folders reviewed had no documentation regarding family structure. 48% of the patients had documentation of other siblings, with most of the children having 2 to 3 other siblings. In terms of financial security, found that 22% of the parents were unemployed. 22% of the parents were employed, 28% of the parents were unemployed. 2% of our patients' mums were still attending school, and 45% were not documented in folders. Care dependency grants. Care dependency grants is given to children who have severe mental and or physical disabilities and require full-time and special care. It covers children from birth up until 18 years of age, and a state medical officer must assess the child before a grant can be approved. If the child is found eligible for a grant, he or she is given 1,200 Rand per month. So we found that 39% of the families received a care dependency grant, 15% were not receiving a grant but an application had been made, and 45% had no documentation of either an application being made or a grant being received. Where are our children now? 29% of the children are still being seen at Red Cross Hospital. 19% of the children are being seen at surrounding hospitals in their local districts or are being reviewed in private services. 26% of the patients were lost to follow-up. 11% of the population were placed, and they were placed either in schools or special care centres according to their level of ability. This is a responsibility which is undertaken by the Developmental Service. 15% of our patients did pass away. 58% of those were in hospital, and they were all related to infectious-related diseases. 42% of the patients passed away at home, and the cause of death remains uncertain. So what conclusions can we draw? So the folder review revealed that the majority of children with Down syndrome are seen frequently at genetics clinic and received appropriate counselling when they were seen at genetics clinic. Cardiac assessments were made frequently and as promptly as possible, and early intervention services were sought as quickly as possible. However, thyroid function tests were not performed timeously and often not appropriately. And whilst children were plotted on growth charts, the use of specific Down syndrome growth charts remained infrequent. In terms of hearing and visual screening, because this only occurred if a clinical abnormality was detected, there remains a significant difference between what is noted between the actual recommendations and guidelines and between what was happening at Red Cross. What are some of the reasons which may contribute to our findings? So we find that our patients have poor financial support and family structure, and this is coupled with living very far from the hospital and relying heavily on public transport. As a result, there is poor hospital attendance. With lack of caregiver education and awareness, we found that many of our patients are lost to follow-up. We also have a high burden of infectious diseases. We found that 4 of our patients were exposed to HIV, with 1 patient being found to be positive. 19% of our patients have been diagnosed with TB at some point in their care, and numerous hospital admissions for acute respiratory illnesses and gastroenteritis were documented. Healthcare systems are not structured appropriately and overburdened, and as a result, there's a larger emphasis on getting children well during an acute illness, but failing to realize that they also need long-term care and follow-up planning. Medical professionals are not cognizant or also aware of guidelines that may exist regarding the care and the long-term follow-up that Down syndrome children may need, and as evidenced, we have very poor record documentation. What can be done? Educational programs can be arranged and can be targeted to better help the caregivers understand what Down syndrome is. Again, these educational programs need to be projected at a level that our mums can understand and that our mums realize the importance of long-term follow-up. A specific protocol or follow-up program needs to be And this is not just for children in Cape Town, but across South Africa, so that children are managed appropriately throughout the country. Provision of a Down syndrome health card, which can be incorporated into the Road to Health card, which children in South Africa have. The health card can document hospital visits as well as investigations and procedures which have been done, as well as the results, so that we do not give the care that is needed and do not duplicate investigations. And also greater utilization of a multidisciplinary approach, so that we can cut down on the number of clinic visits that children have to make and try and coordinate care so that as many visits can be done on the same day visits, rather than allowing patients to come in repeatedly when the cost of getting to hospital remains very high. I'd just like to acknowledge again the families and the children at Red Cross Hospital and thank them for the photos. Mrs. Balboy at Toy Library, who was very helpful, and again Dr. Donald and Dr. Fegan for their help.